Imagine, right, that you're standing in a crowded, just totally chaotic emergency room.
Oh, yeah. The absolute worst case scenario.
Exactly. The monitors are blaring that incessant rhythmic alarm. Your loved one is in the bed, their heart is failing, and the medical team is just, well, they're visibly stumped.
Right. The pressure is unimaginable.
Totally. So the attending physician turns to a computer terminal. They type in this whole cascading failure of symptoms, basically hoping for a lifeline, right? Like an immediate answer from the most advanced artificial intelligence on the planet.
And you'd expect it to just spit out the diagnosis.
Right. But it doesn't. The AI just completely refuses to give a diagnosis.
Wait, it just says no.
Basically. Instead, the screen blinks and the machine asks the doctor this highly targeted, incredibly difficult question about some subtle inconsistency in the blood work. Yeah. It forces the doctor to pause, reconsider their entire train of thought, and just fundamentally change their approach. So today on this deep dive, we are looking at why an artificial intelligence that deliberately refuses to give you the answers might just be like the most important medical breakthrough of our time.
And honestly, quite possibly something that could save your life one day.
Exactly. But it is a really jarring concept, right?
It completely is. I mean, we have been culturally conditioned to view AI as, well, basically the ultimate answer machine.
Yeah, you type a prompt, you get a result.
Right. It gives you a polished essay or a pristine line of code or, a structured business plan.
Yeah.
And the prevailing anxiety right now is that this dynamic is just outsourcing human thought.
Like it's making us lazy.
Exactly.
Yeah.
Systematically degrading our critical thinking because the machine does all the heavy lifting while we just sit back passively and consume it. But the framework we're unpacking today, which is called Vibe Rounds, introduced in June of 2026 by Dr. Avinash Kumar Gupta, it represents a complete structural inversion of that whole relationship.
Yeah, and the documentation makes it incredibly clear upfront what Vibrance is not. Like, you don't feed it a list of symptoms and get a printout that says, the patient has lupus.
Right. It is fundamentally not a diagnostic oracle.
No, not at all. The developers actually describe it as a Socratic AI paradigm engineered specifically for clinical reasoning. And to really wrap your head around the ambition here, the source material draws a direct line to something called vibe coding.
Which is fascinating in itself.
Yeah. So for anyone listening who maybe doesn't follow software engineering trends, vibe coding just completely revolutionized how developers build applications.
Right. Instead of painstakingly typing out every piece of syntax.
They're missing the semicolon, spending hours debugging.
Exactly. The developers just started using natural language.
Yeah, they would just describe the vibe or the architectural intent of the software, and the AI would handle all the boring boilerplate coding.
And that mechanism is so crucial to understand because it really reveals the intent behind vibe rounds. Like, vibe coding didn't replace the software architects, right? It elevated them. By removing all that cognitive load of syntax and rote memorization, the human developer suddenly had the mental bandwidth to focus entirely on, higher order logic and complex system design.
And Dr. Gupta's thesis is that clinical medicine is basically drowning in its own version of syntax, right?
Precisely. Doctors are just overwhelmed by electronic health records, insurance billing codes, all this raw data.
Yeah, it's just operational noise.
Right. So VibeRounds is an attempt to clear that noise. It acts as this cognitive exoskeleton, giving the clinician the bandwidth to actually engage in deep, uninterrupted diagnostic reasoning.
Which is it's a tool designed to train the mind, not replace it. And I really want to emphasize this for everyone listening, even if you never set foot in a medical school, the underlying architecture of how this AI forces a human to think harder is deeply relevant to you.
Oh, absolutely.
Whether you're leading a corporate strategy session or analyzing a volatile market or just trying to navigate a terrifying medical diagnosis for a family member, the ability to rigorously interrogate a problem is a superpower.
Because facts have a shelf life.
Exactly. The rigorous process of critical reasoning does not. But to build an AI that can facilitate that kind of rigorous reasoning, the developers had to overcome this massive, immediate hurdle, which was data privacy.
Yeah, that's the elephant in the room with medical AI.
Right, because in healthcare, the second you mention feeding patient symptoms into some third-party cloud server, institutional firewalls just slam shut.
I pay compliance, data sovereignty, the risk of a breach.
Yeah, these are usually totally fatal bottlenecks for medical AI adoption. But the technical elegance of how they bypass this is just fascinating. The documentation outlines a feature called Bring Your Own Key.
which completely sidesteps the traditional software as a service model.
Yeah. Can you unpack how that actually works under the hood?
Sure, so the architecture relies entirely on local browser-side compute for its orchestration. Basically, when a user logs into VibeRounds, they aren't sending their data to Dr. Gupta's servers at all.
So where does it go?
Well, the user inputs their own API key from whatever large language model provider they prefer, OpenAI, Anthropic, Google, whatever. And that key is encrypted and stored exclusively in the user's local browser storage.
Oh, wow. So it never leaves their computer.
Exactly. When the doctor types in a patient's case, the VibeRounds interface structures the prompt and sends it directly from that local machine to the chosen LLM via the API. The patient data never traverses a centralized VibeRound server.
It just creates this closed, localized loop, which is brilliant because it effectively neutralizes all that institutional paranoia. There's literally no central database for hackers to breach.
Right. But honestly, the real magic isn't the data routing. It's the psychological manipulation of the AI itself.
Yeah, because large language models are inherently, well, they're sycophants.
They're total people pleasers.
Right. They are trained on human feedback to be helpful. And in their minds, helpful means giving you the most direct answer as quickly as possible.
Which is the exact opposite of the Socratic method.
Exactly.
Yeah.
So to stop the AI from just handing over the answer, the VibeRound system employs this rigid set of constraints.
And those constraints are the operational core of the whole thing. Because if the AI just tells you what to do, the educational value drops to zero.
Right.
So the first constraint is what the framework calls forced commitment first. The prompt architecture explicitly forbids the AI from offering any scaffolding, any hints, or any direction at all until the human user has put a tangible hypothesis on the table.
So you must offer an initial guess.
Right. Differential diagnosis or proposing a next clinical step. You have to put your chips on the table before the dealer flips the cards.
You cannot passively consume the AI's brilliance. I love that. And they take that a step further into the actual timing of the interaction, right?
Yes, this is my favorite part. Human experts naturally use silence as an educational tool.
Oh, absolutely.
So the VibeRounds framework simulates this through the 10-second rule, which they also call delayed rescue.
Okay. What does that look like in practice?
Well, when a user submits a particularly weak or incomplete thought, the interface deliberately pauses. It forces the user to sit in that uncomfortable digital silence.
Oh, man, I can physically feel that silence. Anyone who has ever been in a classroom knows that specific, terrifying silence. When the professor asks a question, you give a half-baked answer, and instead of correcting you, they just stare at you.
Right. It makes you sweat.
It totally makes your brain scramble to find the flaw in your own logic before they point it out. Programming an AI to weaponize silence is just brilliant.
It completely breaks the instant gratification loop of modern technology. And when the system finally does break the silence, it utilizes something called tiered hints.
Okay, so it still doesn't give you the full answer.
No, mathematically, the AI is constrained from providing a complete conceptual model on the first pass.
So if a user is struggling to diagnose our patient from the ER with the failing heart.
Hint 1 is strictly broad. It might just point out a specific organ system to reconsider.
Okay.
And if the user still fails, hint 2 narrows the aperture, maybe focusing on a specific class of medications the patient is taking.
And then hint 3.
Hint 3 might offer a partial mechanism of action. The system forces the human to walk as far down the cognitive path as possible before offering the next stepping stone.
And it's constantly evaluating the effort you're putting in, right? The sources call this effort-weighted assistance.
Yes.
So let's say a medical student is just exhausted. It's like 2 a.m. on a rotation, they are fed up, and they just type IDK into the prompt box.
Oh, standard AI would just say, no problem, here's the answer.
Right. But VibeRounds reads the input, analyzes the semantic effort, scores it as functionally 0, and actively refuses to rescue them.
It's so harsh, but so necessary.
Yeah, it will return a prompt saying something like, identify one symptom you think is most concerning, and we will start there. It literally will not fill the void until a minimum threshold of cognitive labor is met.
Consider the analogy of physical training, right?
Okay.
The way we traditionally use AI is basically akin to hiring a chauffeur. You get into the backseat, give the address, and fall asleep.
Right. The machine navigates the traffic, makes the turns, and you wake up at your destination having exerted 0 effort.
And learn nothing about the route.
Exactly.
But VibeRounds operates as a cognitive personal trainer. The trainer spots the barbell while you're attempting a max weight squat. They monitor your form, they ensure you don't crush yourself, and if you get stuck at the bottom of the movement, they apply just enough upward pressure to keep the bar moving.
But they absolutely mandate that your muscles do the lifting.
Because if they lift it for you, their muscle hypertrophies,
Mhm.
not yours. And in this case, the muscle is clinical reasoning.
That distinction between the chauffeur and the trainer, it really requires a deep dive into how human beings actually acquire complex skills in the first place.
Yeah, the underlying pedagogy is fascinating.
Right. The source material grounds this entire philosophy in a concept called the pedagogical spectrum. It basically maps out 5 distinct stages of learning, moving from a rigid, instructor-centered environment all the way to complete learner autonomy.
So stage 1 is the lecture. Yeah.
Exactly. This is the foundational transmission of knowledge.
And the lecture is crucial, for vocabulary and mapping the territory. The educator holds all the expertise. The learner is just a passive receptacle.
Yeah, because you can't reason your way into knowing the names of the cranial nerves. You simply have to be told what they are.
Right. But the framework notes that learning cannot permanently reside in stage 1.
Because then you just become a parrot. You can recite facts, but you can't apply them to a novel situation. So the spectrum naturally moves to stage 2, which is dyadic learning.
Peer-to-peer clarification.
Exactly. You leave the lecture hall, sit down with a classmate, and try to explain the concepts to each other. It forces articulation.
But stage 2 has a pretty fatal flaw.
We is.
If both peers fundamentally misunderstood the lecture, they're just going to reinforce each other's ignorance.
Oh, that's so true. The blind leading the blind.
Right. They lack the authoritative friction required to expose those deep conceptual errors. And that necessitates the shift to stage 3, Socratic learning.
The stress test.
Exactly. The educator pivots from being a lecturer to being an inquisitor. They ask why, and what if the lab results were inverted?
Which exposes the fragile assumptions the learner didn't even know they were making. And Vibrams is engineered to operate as a permanent resident of stage 3.
Yes.
Right?
And stage 4 then moves into guided discovery. The sources describe the educator here not as a questioner, but as an architect of experience.
Right. Okay, what does that mean?
The AI basically sets up a scaffolded environment where the answer is obscured, but the environmental variables are manipulated, so the learner is highly likely to stumble upon the truth if they exert enough effort.
Got it. And finally, stage 5 is research, which is just pure mastery and independent inquiry at the absolute edge of human knowledge.
Right. And the underlying psychology governing movement across all these stages is cognitive load theory.
Okay, unpack that for us.
So the human brain has a finite amount of working memory, right? If you take a first-year medical student who barely understands cellular biology and drop them into stage 5.
Like asking them to construct a novel treatment protocol for an autoimmune disease.
Exactly. Their cognitive load spikes way past capacity. They just drown in the ambiguity and learn absolutely nothing.
But the inverse is just as dangerous, isn't it? If you coddle a fourth-year student by keeping them in stage 1, endlessly feeding them polished lectures and flashcards, they never develop the tolerance for ambiguity that real medicine requires.
Because patients don't present as flashcards.
No. They present as messy, contradictory puzzles. And the source text actually calls Vibrams an MRI for clinical thinking.
I love that phrase.
Right. Because normally, when an attending physician watches a resident, they only see the final diagnosis, the actual cognitive leaps, the discarded hypotheses, the moments of hesitation that is all invisible.
But Vibrams digitizes that entire thought process, making every single step of the reasoning journey visible and auditable.
Okay, but I do want to push back on the framework's disdain for those early stages, though.
Okay, let's hear it.
If Vibrams is aggressively pushing learners into stages 3, 4, and 5, isn't there a massive risk of alienating absolute beginners? Like, if a student legitimately does not know the pharmacology of a beta blocker, having an AI hit them with Socratic questions is just going to be infuriating.
Oh, totally.
It's like asking someone to write a poem in a language they don't speak.
That's a great point, and the developers actually anticipated that exact friction. The architecture is not some blunt instrument. It doesn't apply universal Socratic pressure to everyone.
So how does it handle beginners?
Vibrams is built to dynamically assess the foundational knowledge base of the user in real time. So if it detects that the user lacks the stage 1 vocabulary, the AI temporarily downshifts.
Okay, so it dials back the pressure.
Exactly.
Yeah.
Provides a highly targeted micro-lecture just to fill that specific knowledge gap, and only then does it return to the Socratic mode to test application. It supplements the foundation, it doesn't ignore it.
Which is pretty amazing. But that brings us to the actual mechanics of how you program a large language model to perform this kind of dynamic educational
Right,
gymnastics.
because standard chatbots just predict the next most likely word based on their training data.
Exactly. To force them to act as a nuanced, adaptable Socratic tutor requires a highly specialized operating system, and the documentation introduces this as the Clinical Cognition OS, or CCOS.
Right, and CCOS fundamentally reimagines how we even interact with language models. It is not a monolithic application with a traditional database.
It's described as a structured prompt architecture, right? A complex system of composable prompts and operational pipelines.
Yes, and to really understand it, you have to break down its structural hierarchy. Modules, agents, and pipelines.
So let's define those because the terminology gets pretty dense. A module is the foundational building block.
Right. Think of it as a single cognitive lens.
Okay, so a module is designed to do one very specific, highly constrained task. Like, there might be a module exclusively dedicated to extracting diagnostic anchors, or one purely for identifying logical fallacies in a paragraph of text.
Exactly. Moving up the hierarchy, you then have the agent. An agent is a specialized cognition engine that orchestrates multiple modules simultaneously.
So it manages the flow between those smaller blocks.
Right. It holds a specific persona and manages that data flow. And finally, the highest level is the pipeline.
Which is what?
A pipeline is a structured end-to-end workflow that chains multiple agents and modules together to take a user on a progressive reasoning journey, from raw data all the way to a calibrated conclusion.
Got it. And this entire hierarchy operates across 6 distinct cognitive layers.
Let's run through those.
Okay, layer 1 is reasoning, which is the basic mechanics of generating a differential diagnosis. Layer 2 is workflow, managing the sequence of how information is processed. Layer 3 is metacognitive, the AI monitoring the human's assumptions and biases.
And layer 5 is decision architecture, structuring conservative versus aggressive treatment plans. Layer 6 is learning and documentation.
But we skipped layer 4, and honestly, layer 4 is the absolute crown jewel of this operating system, the mechanism that makes it actually viable in a life-or-death clinical setting.
The epistemic trust layer.
Yes, the epistemic trust layer addresses the most critical flaw in generative AI hallucination.
Which is huge because in creative writing, an AI hallucinating a detail is just a feature, it's imagination.
Right. But in clinical medicine, an AI hallucinating a drug dosage or a statistical probability is literally catastrophic.
So layer 4 is a set of prompt-level algorithmic constraints that strictly govern how the AI calculates, expresses, and communicates uncertainty.
And the text highlights a specific mechanism here called the suppression of false numerical precision. I want to dive deep into this because it really exposes how LLMs actually think.
It's wild. If you ask a standard AI for the mortality rate of a rare condition, its token prediction algorithm inherently wants to sound authoritative.
Right. It will frequently generate a highly specific, completely fabricated number. It will confidently tell a doctor the mortality rate is exactly 13.7%.
And the danger there is that humans are naturally anchored by specific numbers.
That 13.7% sounds researched and absolute.
Exactly. So what layer 4 does computationally is intercept that token prediction. The system's prompt architecture mandates that unless the AI can pull a direct, verifiable statistical citation from an integrated medical database, it is completely forbidden from outputting numerical probabilities.
That's a hard stop.
A total hard stop. It forces the AI to translate that hallucinated precision into ordinal relative language. The AI is restricted to saying something like the mortality risk appears moderate compared to baseline.
So it strips away the illusion of mathematical certainty.
Completely.
It also employs a protocol called prioritized claim verification. Because, in early iterations of AI fact-checking, developers tried to force the system to verify every single word it generated.
Which is computationally ruinous and incredibly slow.
Oh, painfully slow.
Yeah.
So CCOS takes a risk-based approach instead. The AI is programmed to identify which of its own claims are actually load-bearing.
Consider the workflow of an experienced medical editor. If a resident submits a case report, the editor doesn't spend hours verifying the brand of the stethoscope mentioned in the preamble.
Right, who cares?
But if the resident claims a specific off-label use of a chemotherapy drug cured the patient,
The editor halts the presses and demands 3 independent, peer-reviewed citations.
exactly. The prioritized claim verification mechanism does exactly this. It scans the generated output, completely ignores the narrative filler, and rigorously audits only the claims that would alter a diagnosis or impact patient safety.
It's like having a highly skeptical editorial intelligence layer running constantly, and it goes even further with confidence calibration.
Right, because usually an AI gives you one monolithic answer with a uniform tone of absolute certainty.
Yeah, but the epistemic trust layer forces the AI to separate its confidence into distinct domains. So the AI might output something like, I am highly confident in the diagnosis of acute pancreatitis based on the lipase levels. However, I have low confidence in the underlying etiology because the ultrasound imaging provided is inconclusive,
It's mapping the typography of its own certainty.
which is incredibly useful for a doctor. Now, integrated tightly into this operating system are four meta-skills frameworks that govern the actual conversational dynamic.
And the first one is the humanistic persona.
Yes, and the cardinal rule of this framework is that the AI must explicitly name and affirm a specific correct reasoning move made by the user before it issues a Socratic challenge.
And this isn't just about the AI being polite, right?
No, not at all. There is a deep psychological mechanism at play here. If a medical student offers a flawed hypothesis and the AI instantly attacks the flaw, the student's brain triggers defensive cognition.
Their ego feels threatened.
Exactly. Their amygdala flares and they stop processing new information. They just defend their initial stance.
Right, so by forcing the AI to say, your identification of the elevated white count as a sign of systemic infection is spot on, but let's re-examine why you immediately assume the source is respiratory, it bypasses that ego defense.
It validates the intellect, keeping the learner open to the subsequent friction.
It's so smart. And the operating system also weaves in two renowned educational models, Fink's Flink taxonomy and Bloom's revised taxonomy.
Most people are probably familiar with Bloom's ladder, right? Moving from basic rote memorization at the bottom up through understanding, applying, analyzing, evaluating, and finally creating at the top.
Right, and the AI dynamically tracks where the user's logic resides on Bloom's ladder and prompts them to move one rung higher.
But Fink's Flink taxonomy is less widely known, and I honestly think it's the secret weapon here.
Oh, absolutely. While Bloom's focuses purely on cognitive processing, Fink's taxonomy introduces the human dimension.
What does that look like?
It forces the learner to consider the caring aspect, the ethical implications, and the concept of learning how to learn. So the AI might pivot from asking about the pathophysiology of a disease to asking, how do you think this specific diagnosis will impact the patient's ability to maintain their current employment?
Wow, so it forces holistic reasoning. It's not just a puzzle to solve, it's a person's life.
Exactly. But the most radical of the four frameworks, in my opinion, is the critical awareness framework.
Okay, unpack that.
We spend so much time worrying about human bias. We forget the AI itself has systemic biases based on its training data.
Right.
This framework programs the AI to actively name its own vulnerabilities in real time.
Really? Like it warns you about itself.
Yes. During a complex diagnostic case, the AI will spontaneously generate a warning. It might say, please be aware, as a language model, I am highly susceptible to automation bias and tend to anchor on rare esoteric diagnoses that appear frequently in medical literature but rarely in clinical practice. Please independently verify the prevalence of my suggested differentials.
That is wild. It's an auditing protocol that actively audits itself, constantly reminding the human not to blindly trust the machine.
It's brilliant.
So we have this elegant philosophy, and we have this incredibly sophisticated engine in the CCOS. Let's actually look at what happens when you turn the key. The Viberound system boasts over 57 distinct reasoning modules and 200 clinical pipelines.
It's a massive learning stack.
Let's take a few of these modules out of the abstract and place them into the crucible of clinical practice. What stands out to you?
One of the most conceptually striking tools in the stack is Module 42, the clinical premortem.
Okay, I love this one.
The traditional postmortem is a cornerstone of medical education. After a patient dies or suffers a catastrophic outcome, the medical team gathers in a morbidity and mortality conference to dissect the chart and figure out what went wrong.
But the fatal flaw of the postmortem is that it's retroactive. The patient is already gone.
Exactly. So Module 42 inverts the timeline. You are in the ICU. The patient is alive but unstable. The doctor triggers the clinical premortem module.
And what does the AI do?
It forces a stark hypothetical. It says, imagine it is 48 hours from now. The patient has suffered a complete cardiopulmonary collapse and is dead. Work backwards. What specific overlooked detail in the current labs or what subtle bias in your current treatment plan caused this failure?
The cognitive shift there is profound. Because when a doctor is treating a patient, confirmation bias heavily skews their perception toward evidence that supports their chosen treatment plan.
Right, they want to believe their plan is working.
Exactly. So by forcing the clinician to adopt the premise that their plan has unequivocally failed, the brain is forced to actively hunt for disconfirming evidence. It completely shatters tunnel vision.
And speaking of shattering biases, there is Module 26, bias auditing.
Oh, this one is fascinating. And this isn't just some generic checklist, right?
No, not at all. The clinician inputs their entire narrative reasoning for a case. The AI scans the text, cross-referencing it against dozens of known cognitive fallacies.
So it calls them out.
Yeah. It might flag a paragraph and say, you have dismissed the patient's joint pain as a chronic baseline issue, but you have no prior imaging to confirm this. You are exhibiting availability bias, assuming the most common explanation without sufficient proof.
That is amazing. Or consider Module 37, which is called the red herring, or the signal-to-noise drill.
Right, because in textbook cases, every symptom points neatly to the diagnosis.
Yeah, but in a real emergency room, a patient might present with a severe headache, a rash, chronic back pain, and a slightly elevated potassium level.
It's just a mess.
Total noise. And the human brain struggles to weigh these competing data points. So Module 37 actively trains the clinician to identify which symptoms are load-bearing architecture, the signal, and which are merely distracting physiological background noise, the red herrings.
The one that fascinates me the most, though, is Module 30, the diagnostic anchor extractor.
Okay, what does that do?
Anchoring is perhaps the most dangerous cognitive trap in medicine. It happens when, say, a triage nurse writes suspected panic attack on the chart of a patient experiencing chest pain.
Right. And then every subsequent doctor who reads that chart subconsciously anchors to the concept of anxiety.
Exactly. They filter all new data through that lens, potentially missing a massive heart attack. So Module 30 analyzes the clinician's input history, isolates the very first diagnostic concept introduced, and forces the user to meticulously justify why that specific concept hasn't been discarded yet.
It forces you to untether yourself. I love that. And to see how all these modules operate synergistically, the source documentation provides a detailed workflow of a pipeline in action, which they refer to as the 42F with severe regular edema case.
Right. A 42-year-old female presents with severe, unexplained swelling.
So the clinician doesn't just trigger one module and get an answer. They initiate a pipeline that chains multiple modules in a specific progressive sequence. Module 1 to 12 to 9 to 21 to 35. Let's walk through that sequence because it illustrates the journey perfectly.
Sure. So the doctor inputs the raw, messy triage data. The pipeline kicks off with Module 1, which is the foundational Socratic intake.
Right. The AI doesn't offer a diagnosis. It just asks the doctor to cluster the symptoms. You noted severe edema and a slight shortness of breath. Which of these do you consider the primary driver, and what is your initial differential?
That a doctor commits to an answer.
Once the human commits, the system routes the output into Module 12, which focuses on expanding and pruning the differential diagnosis.
So the AI analyzes the doctor's initial list and challenges it. It might say, you prioritize cardiac causes for the edema, but given the patient's age and lack of prior cardiac history, what renal or hepatic etiologies are you prematurely dismissing?
It forces lateral extension of thought.
Exactly. So the doctor refines the list, and the data flows into Module 9, which structures the refined hypotheses into a formal, testable clinical protocol.
And then the system triggers Module 21. This is the evidence frontier search.
What happens there?
The AI takes the structured protocol and queries integrated medical databases, cross-referencing the doctor's plan against the absolute latest peer-reviewed literature, looking for novel contraindications or emerging therapies that match the specific patient profile.
And finally, the entire journey culminates in Module 35, epistemic certainty mapping.
Synthesizing it all.
Right. The AI synthesizes the initial data, the expanded differentials, the literature review, and generates a calibrated confidence score for the final assessment.
It essentially grades the structural integrity of the doctor's final conclusion based on the rigor of the preceding steps.
It transforms a totally chaotic clinical encounter into a highly structured, auditable reasoning pathway.
Okay, but tracing this complex multi-step pipeline raises a massive logistical vulnerability, doesn't it?
Oh, you mean the compounding errors?
Exactly. We are chaining 5 different AI interactions together. If the AI hallucinates a subtle detail in Module 12, That error infects Module 9, compounds in Module 21, and catastrophically corrupts the final output in Module 35.
It's a huge risk.
If you're using the AI to audit human bias, what mechanism audits the AI during a prolonged pipeline? Who watches the watchman?
This is where the architecture of the CCOS reveals its absolute brilliance.
Right.
The developers recognize the danger of compounding hallucinations. So to counteract it, they engineered shadow modules.
Shadow modules.
Yeah, the documentation details that for highly complex operations, the primary AI module has an adversarial twin running silently in the background.
So if the doctor is running Module 44 for clinical genetics reasoning,
Shadow Module 45 is operating simultaneously behind the scenes.
what is its job?
The Shadow Module's singular directive is adversarial cross-examination. It doesn't interact with the human user at all, it just monitors the output of the primary AI.
So it's hunting for errors?
Exactly. Its job is to hunt for logical leaps, fabricated citations, or instances where the primary AI subtly shifted a statistical probability between steps.
Give me an example.
Say the primary AI states in step 2 that a genetic marker has a 40% prevalence, and then implies in step 4 that it is a majority indicator. The shadow module flags that logical drift, interrupts the pipeline, and forces the primary AI to correct its own inconsistency before presenting the next prompt to the user.
That is mind-blowing. It is a self-contained computational devil's advocate. It's an AI defense attorney relentlessly cross-examining the AI prosecutor to ensure the jury, the human doctor, only sees verified evidence.
It is a staggering level of safety engineering.
It really is.
Yeah.
Now, we have spent a lot of time in the clinical weeds discussing how this benefits seasoned doctors running complex pipelines. And it would be really easy to assume that Vibarounds is just this elite tool restricted to research hospitals and gray-haired attending physicians. But the true scale of this framework lies in its adaptability.
Oh, completely. The system is entirely modular regarding the persona it adopts. Through specific LLM prompt commands, the user can instantly recalibrate the AI's pedagogical approach.
So it alters the power dynamic of the conversation.
Fundamentally, to match the user's specific stage of medical training, or, crucially, their lack of medical training.
Okay, let's explore these personas. Imagine you are a preclinical medical student. You are in your first month of medical school. You don't know anything about clinical management. You are just desperately trying to memorize the Krebs cycle and the branches of the aorta.
Right, you're terrified and overwhelmed.
Exactly. So you select the prompt command to initiate the friendly senior medical student persona. What happens?
In this mode, the AI completely abandons the intense Socratic pressure of, say, a clinical premortem. The prompt instructions mandate that the AI use simple, non-threatening analogies to build conceptual bridges.
So it's much gentler.
Way gentler. If the student is struggling to understand how the kidneys filter blood, the AI might compare the nephron to a complex coffee filter system.
Okay, I like that.
It asks gentle, leading questions to assess baseline knowledge, and if the student uses the wrong terminology, it doesn't penalize them. It warmly corrects the phrasing and asks them to apply it in a new sentence. It operates as a tireless, infinitely patient study partner.
But fast forward 3 years. You are now a junior resident. You are working a night shift, making independent management decisions that affect living patients.
The training wheels need to come off.
Exactly. You trigger the command for the Socratic attending.
Now, the Socratic attending persona is a masterclass in educational friction. The prompt explicitly commands the AI to never accept a resident's initial assessment at face value.
So if the resident confidently types, "The patient has a pulmonary embolism. I am ordering a CT scan."
The AI will flat out refuse to validate the order. It will demand, defend your prioritization. If your top diagnosis of a pulmonary embolism is incorrect, what is the most lethal alternative that you are currently ignoring? What specific data point in the patient's vitals contradicts your theory?
Wow.
Its objective is to aggressively expose the soft spots in the resident's clinical armor.
And nestled right between those two extremes is my favorite persona, the supportive intern.
Oh, the clerkship one.
Yeah. This is designed for clerkship students who have just stepped onto the hospital ward for the very first time. They have all this textbook knowledge, but they are terrified of making a mistake in front of a real doctor. The genius of the supportive intern prompt is its restraint.
Because it acts as a peer.
Exactly. The AI is instructed to act as a peer and to ask exactly one pointed question about a missed detail. Not a barrage of questions, just one.
Right. So if the student proposes a treatment plan but forgets to check the patient's kidney function before suggesting a specific antibiotic, the AI doesn't berate them.
It simply says, I agree with the antibiotic choice, but what should we verify about their renal clearance before we finalize the dose?
It provides a single thread for the student to pull on.
Allowing them the dignity of discovering their own error, it just calibrates the cognitive load perfectly. But what elevates Vibarounds from a fascinating medical school tool to a potentially world-changing framework is that it extends beyond the medical profession entirely.
Yes, the non-medical users.
Right. The source material dedicates significant architecture to family caregivers and patient advocates.
And that is so important because the healthcare system is notoriously hostile to the uninitiated.
Oh, absolutely.
When a family member is suddenly thrust into the role of caregiver for a patient with a complex chronic illness, they are just overwhelmed by a tsunami of fragmented information.
And Vibarounds addresses this with Module O2, Patient Advocate Case Documentation.
Right. Anyone who has taken an elderly parent to a specialist knows the panic of the 15-minute appointment.
It's awful. The doctor walks in, asks what's wrong, and the caregiver fumbles through a notebook trying to remember timelines, symptoms, and medication changes.
But Modulo 2 allows the caregiver to sit down in the calm of their own home and interact with the AI. The AI patiently asks chronological questions, helps clarify the severity of symptoms, and structures the scattered narrative into a highly organized, clinically coherent timeline.
A timeline that a human doctor can digest in like 30 seconds?
Exactly. It acts as an interpreter, translating the messy lived experience of the patient into the structured vernacular of clinical medicine.
And it goes further with Module 11, Patient Education Query Intelligence.
Which is for newly diagnosed patients.
Right. When a patient receives a terrifying diagnosis, say, multiple sclerosis, they often leave the clinic in a state of shock. They don't even know enough about the disease to know what questions to ask.
It's the unknown unknowns.
Exactly. Module 11 is designed to map those unknown unknowns. The patient inputs their diagnosis and their general anxieties. The AI generates plain language explainers using relatable analogies. But most importantly, it surfaces the unspoken questions.
Like what?
It generates a list of crucial questions the patient should take back to their doctor, questions about long-term mobility, specific side effects of the new medications, warning signs of disease progression. It even generates a medication literacy table, breaking down exactly what each of the 5 new pill bottles does and why timing matters.
That is incredibly empowering.
Okay, but I have to stop here and raise a massive flashing red flag on behalf of the listener.
Go for it.
We are talking about giving an immensely powerful medical AI reasoning engine to a terrified husband at 3 a.m. whose wife has a severe migraine. What is stopping him from using this system, bypassing the doctor entirely, and deciding his wife has a terminal brain tumor based on a hallucinated Socratic rabbit hole? Isn't deploying this to untrained civilians incredibly dangerous?
That is the most critical vulnerability of the public-facing application, without a doubt. And the developers address it through rigorous mechanical safeguards, not just polite little disclaimers at the bottom of the screen.
Okay, so how does it stop them?
The ground rules of Vibarounds dictate that it is strictly an educational reasoning aid. For non-medical personas, the system's ability to generate diagnostic differentials is computationally locked.
So it won't even entertain the attempt to diagnose.
Exactly. If a caregiver inputs symptoms and demands a diagnosis, the AI mechanically refuses. It redirects the intent.
What does it say?
The AI will respond with something like, "I cannot diagnose this condition." However, based on the symptoms you've provided, here is a structured list of targeted questions and specific timeline details you should present to your urgent care physician immediately.
So the entire output formatting is engineered to culminate in a human-to-human clinical encounter.
Yes, it organizes the caregiver's thoughts to make the upcoming doctor's visit more efficient. It does not replace the visit. It empowers the patient to be a formidable advocate, a prepared partner in their own care, rather than a passive, terrified recipient.
That mechanical lock is vital. It shifts the tool from a WebMD symptom checker that just induces panic into a strategic planning tool for medical advocacy.
Exactly.
So we have seen how Vibarounds scales down to help a first-year student learn the basics, and how it scales sideways to help a father advocate for his sick child. But the final frontier of this system operates at the absolute edge of human knowledge. We're moving beyond the classroom and the clinic and into the realm of Stage 5 research and evidence mapping.
Right. Stage 5 is where the parameters of what is known end and independent inquiry begins. And the framework facilitates this through advanced protocols like Modulo 9, the N of 1 case research protocol.
Now, in traditional research, you look at massive populations, right?
Usually, yes.
Yeah.
But an N of 1 trial is a clinical trial where the sample size is a single patient.
Just one person.
Just one. It is used for incredibly rare diseases where large populations simply don't exist, heavily monitoring that single patient over time with alternating interventions to prove causality. Module O9 helps a researcher dynamically structure the rigorous statistical parameters required to make a single patient trial scientifically valid.
That's fascinating, but the true masterpiece of Stage 5 capability is highlighted in a specific flagship demonstration detailed in the sources, the anti-snake venom, or ASV mortality benefit evidence map.
Oh, this case study is brilliant.
I want to unpack this ASV case study in detail because it brilliantly exposes a fundamental systemic flaw in how modern evidence-based medicine processes information and how Vibrarounds corrects it.
Okay, so the core clinical question seems incredibly simple, right?
Yeah.
Does anti-snake venom actually save lives? Does it have a proven mortality benefit?
Right. And the gold standard of modern medical evidence is a randomized controlled trial, the RCT, or a massive meta-analysis combining multiple RCTs.
If a drug works, you expect to see it proven in an RCT.
However, if you run a search through top-tier medical databases, RCTs and meta-analyses do not establish a mortality benefit for anti-snake venom.
Wait, really?
Really? The highest tier of scientific evidence cannot prove that antivenom stops you from dying of snakebite. And the crucial question is why? It is not because the venom isn't deadly, and it is certainly not because the antivenom is ineffective.
So what is it?
It is entirely due to the constraints of medical ethics.
Because to conduct a randomized controlled trial, you must randomize a population.
Exactly. You would have to take a large group of patients who have just been bitten by a highly venomous snake, give half of them the life-saving antivenom, and intentionally inject the other half with a placebo saline solution.
And then just sit back with a clipboard to see if the placebo group dies at a statistically higher rate.
Which is flagrantly, monstrously unethical. It violates every tenet of the Hippocratic Oath.
It is the classic parachute analogy.
Yes. We have no randomized controlled trials proving that parachutes save lives because you cannot ethically push a control group out of a soaring airplane with an empty backpack just to record the impact data.
Precisely. So because of this ethical hard stop, the highest tier of medical evidence is completely blind to the mortality benefit of antivenom.
And this is where traditional generative AI fails catastrophically.
How so?
Well, if you ask a standard LLM to review the literature on antivenom mortality, its algorithm naturally prioritizes the highest tier of evidence. It scrapes the RCTs and meta-analyses, finds no statistically significant proof of mortality benefit, forces a synthetic consensus, and confidently outputs a profoundly dangerous conclusion.
It says it doesn't work.
Right. It says there is insufficient evidence to prove antivenom saves lives. It is a systemic blind spot created by the AI mashing all the data into a single smooth output.
Wow. So how does the Vibrarounds architecture approach a problem where the gold standard evidence is ethically blocked like that?
It abandons the forced consensus model entirely. Instead, Vibrarounds utilizes meticulous evidence mapping. It does not throw the research into a blender. It extracts the data paper by paper. And critically, it segregates the evidence by its methodological tier.
So it builds a visual topology.
Exactly. It places the few flawed RCTs, which usually only involve minor bites in one column. It places systematic reviews in another. And it places decades of case reports and historical observational data in a separate, distinct tier.
And when the AI maps the evidence this way, keeping the topology intact, what picture emerges?
The researcher suddenly sees exactly where the truth resides. The true mortality signal, the overwhelming proof that the antivenom works, is heavily concentrated entirely within the lower tiers of evidence.
That case reports, the observational data from rural clinics.
Right, the historical records of massive fatality rates before antivenom was distributed. The AI highlights that this lack of RCTs is not a failure of the drug. It is a structural artifact of how medical ethics shape clinical data.
So it prevents the dangerous pooling of incompatible units of data.
Yes. It refuses to let the absence of an RCT erase a century of valid observational truth. It provides the researcher with a transparent, source-traceable blueprint of why the evidence looks the way it does.
Think about the broader implications of this mechanism.
Yeah.
We live in an era defined by a suffocating avalanche of information.
Oh, totally.
Traditional AI promises to save us from this overload by synthesizing everything into a single, easily digestible paragraph. But in doing so, it destroys the context. It destroys the nuance.
It blends it into gray sludge.
Exactly. Vibrarounds proves that treating research like a mosaic, where every single tile, every case report, every outlier study remains distinct and structurally intact, allows the human mind to step back and perceive the actual complex picture.
without the colors bleeding into that muddy, inaccurate gray. And for anyone listening, whether you are analyzing a massive trove of medical literature or conducting deep market research on consumer trends, or just trying to understand the conflicting historical accounts of a geopolitical crisis, the ability to map evidence while preserving the integrity and context of the individual data points is an absolute superpower.
It allows you to see where the data is robust,
Hmm.
where it's fragile, and most importantly, it forces you to understand the underlying architecture of why the information is structured the way it is.
It is a profound shift in utility. We have spent this whole deep dive dissecting the mechanics of this system, from the local storage privacy protocols and the delayed rescue silences, to the hallucination-suppressing epistemic trust layer, and finally to this mosaic of evidence mapping.
And the connective tissue running through all of it is just a fundamental respect for human cognition.
Yeah. We started this deep dive with a shared cultural anxiety. The fear that artificial intelligence is destined to make us lazy, that it will slowly atrophy our critical thinking muscles until we are entirely dependent on the machine to make sense of the world.
But the Viberon's framework offers a radically optimistic counter-narrative.
It really does. It proves that the highest, most noble use of artificial intelligence is not to replace human intellect by spoon-feeding us polished answers.
The highest use of AI is to serve as a tireless, brilliantly calibrated sparring partner.
Right.
A system that scales Socratic rigor to match your exact level of understanding. An AI that forces you to confront the biases you didn't know you harbored, to defend the logical leaps you took for granted, and to engage so deeply with the material that the knowledge becomes permanently etched into your mind.
By refusing to give us the easy answer, it forces us to become sharper, more empathetic, and fundamentally more autonomous thinkers. It is a total reimagining of the human-computer relationship.
Not as a master and servant, but as a crucible for intellectual growth.
We've covered a massive amount of ground today, exploring a framework that I truly believe will redefine not just medical education, but how we interact with information across every discipline. I hope this exploration has shifted how you view the potential of the AI tools you interact with every day. But before we sign off, I want to hand it over for one final provocative thought, something for you to mull over as you step back into your day.
This journey raises a fascinating question that echoes back to the anxieties we discussed at the very beginning. We spend so much time and energy wringing our hands, terrified that artificial intelligence will eventually outsmart us, that it will compile all the answers in the universe and render human inquiry obsolete.
Right.
But looking at the philosophical core of AI that questions, I wonder what if the ultimate lasting legacy of artificial intelligence isn't the vast passive library of answers it generated to make our lives easier? What if its greatest contribution to the evolution of humanity is the incredibly difficult, uncomfortable questions it finally forced us to ask ourselves? That is a brilliant thought to leave on. Thank you so much for joining us on this deep dive into the architecture of thought. Stay insanely curious, keep pushing the boundaries of what you think you know, and remember that the best way to learn, the only way to truly understand, is to never stop questioning.